Hi, everybody. I am going to speak about post-extubation laryngospasm today, strictly in the perioperative sense. What is laryngospasm? It's actually the sustained contraction or closure of the true vocal cords, resulting in partial or complete loss of the patient's airway. It's actually a protective reflex which would help in preventing aspiration of secretions or any food material from the mouth into the trachea and in towards the lungs. So it's not amenable to normal airway positioning maneuvers like head tilt and jaw thrust because the problem is basically at the level of the larynx. What is the incidence? It occurs overall with an incidence of 1% if you take into consideration the adults in the pediatric age group. But in infants and school children, it is almost double. And in children below 3 months, it's almost triple the adult values. So highest would be between 1 to 3 months. Those with reactive airways disease, asthma, no? So children especially, it's going to increase to almost 10%. And in surgeries like tonsillectomy and adenoidectomy, it can go up to 25% in terms of the risk of occurrence. So to understand laryngospasm, a slight overview of the nerve supply of the vocal cords. So primarily the vocal cords are supplied by the superior laryngeal nerve, the external branch and the internal branch, and the recurrent laryngeal nerves. And they carry both sensory fibers and the motor fibers, and they also carry autonomic fibers. There is an abundant autonomic supply around the area of the larynx and the supraglottis. And they overall, these nerve innervations are for the sake of maintaining normal functions in terms of phonation, respiration, and cough reflex for the patient. So in fact, they are quite protective. When we say protective, they are controlled reflexes or inhibitory reflexes from the CNS also, which is good for the patient. However, if this controlled or inhibitory reflexes overall is affected due to inadequate CNS depression, especially with strong stimuli, okay, so they can precipitate laryngospasm. So laryngospasm actually is a huge reflex shock. There is a stimulus, as I told you already, something which is in the form of a secretion, blood, saliva, or even foreign bodies or gastric contents in the larynx. They will stimulate the mechanoreceptors. Of course, at extubation, normally, for example, it could be secretions or drops of blood. And the stimulus will elicit afferents to carry the sensation input to the brain. Of course, it is mainly to the nucleus tractus solitarius in the brainstem, and efferents are sent to the motor fibers accompanying the superior laryngeal nerve and the recurrent laryngeal nerve. So, end result would be the adduction of the vocal cords, resulting in the laryngospasm, which we speak about. There are certain risk factors for laryngospasm, even though it is not identifiable in 40% of the individuals. They could be patient-related, anesthesia-related, and surgery-related. The patient-related could be, as I told you already, younger patients are more likely to have this risk, and it's more frequent during extubation rather than intubation in children, and those with history of URTA, asthma, and hyperreactive airways disease per se. And anesthesia-related, it is always more likely during inadequate depth of anesthesia, which we may face during the extubation period. And if you manipulate at this point of time, such as laryngoscopy, then thorough suction and all, it can elicit the stimulus. And in fact, when you speak about the airway device, it is said that risk is the highest. Of course, it is evidence-based, highest with supraglottic devices, more than the endotracheal tube, but more than a backbox ventilation. And among the induction agents, thiopentone is more likely to be associated. And among the inhalation agents, desflurane use as compared to iso, enflurane, hazarotene, and sevoflurane is likely to be associated with a risk of laryngospasm. Surgery related, I told you, tonsil, adenoid surgeries, throat airway surgeries, laryngeal, thyroid, okay, they are more likely to be associated with laryngospasm. So how do the patients present clinically? So this is dependent upon the severity of laryngospasm. It could be partial or it could be complete. When it is partial, means there is some passage available for the air to move in and move out. but patient can have inspiratory stridor as it becomes narrower. Typical stridorless movements and the sounds would be heard. And if you have, because as we do normally, when this patient's airway is connected to the endotracheal tube, and then we have removed it. So there is, we still maintain the bag mask ventilation to the patient. There will be some bag movement, some chest rise, but the patient will be struggling with this respiratory effort, the tracheal paradoxical respiratory movements will be seen. And if you look at the monitor, SpO2 will start falling. And if you try to put a, for example, oropharyngeal airway, it will not work because problem is at the level of the larynx. It's not because of the fallback of the tongue. And if this partial laryngospasm becomes full, there is no airway at all, passage, space for movement of the air. There will be total absence of breath sounds, and our efforts will be very futile. No bag movement, no chest rate, and paradoxical respiratory efforts, and again fall in SpO2, bradycardia, and other things. And of course, if you look at the monitor, you will not be able to see the EtCO2 waveforms and the values, which you may be able to see with a partial laryngospasm. So overall, the greatest risk is oxygen desaturation followed by hypoxia, cyanosis, if you delay in attending to the problem, and of course precipitate tachycardia initially, then bradycardia and asystole. And because patient is trying to breathe, okay, there is risk of negative pressure pulmonary edema, which I will discuss in a single slide later on. There is a potential for death if you don't take care of the patient. So when I told you about the laryngospasm reflex, so there can be management from the point of stimulus to the point where there has already been the laryngospasm. For example, we can have prevention, like from the time we think about the stimulus, which is a risk factor, and the afferents through the sensory nerve fibers to the center in the brain. At the nucleus tractus areas, we can try to have certain preventive measures generally, and treatment can involve all the areas, the afferents, efferents, and the center of the laryngospasm reflex. So simple treatment would be, if the offending stimulus is still present, gently support the secretions, mucus of the blood from the oral cavity. Continue the mask ventilation. Use a best fit mask. Keep it leak proof. Try to push 100% oxygen. IPP with closed expiratory valve. Try to use the best sized oropharyngeal and nasopharyngeal airway if possible for the patient. And we can apply jaw thrust if you think there is some tongue back which is precipitating the event. And if it is so, it will help us in pushing the oxygen into the lungs. And then you can perform what is known as Larson's maneuver, about which I will again explain in next slides. So if these efforts are not useful and laryngospasm is not relieved, what we can do is we can administer propofol 0.25 to 0.8 mg per kg. That will help in deepening the anesthesia and break the reflex, both afferent and the efferents, and the effect on the brain. And you can relax. It's a peripheral action using succinylcholine, 0.1 to 0.5 milligram per kg IV. In fact, literature also speaks about 3 to 4 milligram per kg IM. When you don't have an IV line, for example, or you have lost it, we can have an IM, especially in neonates and infants. And we can continue the manual ventilation with CPAP and consider endotracheal intubation if you are happy that there is some opening. If you fail, you can go ahead with the cricothyroidotomy, very difficult in young children, and tracheostomy. And if you have succeeded, definitely laryngospasm is relieved, and the monitor will show good values, and continue to follow up the patient. There are other options are also discussed. For example, usage of IV lignocaine, about 1 to 1.2 milligram per kg, topical lignocaine, but of course that also adds some volume, and there is a risk of precipitating aspiration, eliciting this reflex. Okay, that it is doubtful. Magnesium sulfate 30 milligram per kg IV, or topical cocaine, usage of doxapram, nitroglycerin have all been mentioned, not generally approved. There is possibly a scope for superior laryngeal nerve block, recurrent laryngeal nerve block. No, otherwise they are just mentioned. So all of them, there is no uniform effectiveness. However, what you have to keep in mind is that supportive measures should be kept ready. For example, atropine loaded and kept to some extent to buy time in the presence of bradycardia, and nasogastric tube, because you are pushing the oxygen inside with the mask and with IPPV, there could be gastric dilatation and it can precipitate splintering of the diaphragm. Already patient is struggling against closed glottis. So something about Larson's maneuver. There is what is known as a laryngospasm notch, first discussed by Larson in his publication in 1998. So it is a site which is anteriorly bound by the ascending ramus of the mandible adjacent to the condyle. Then we have posteriorly the mastoid and cephaloid. It's a base of the skull and external auditory canal. So this is the space where we can bilaterally apply pressure with a moderate jaw thrust, apply for 3 to 5 seconds and release for 5 to 10 seconds and repeat till the spasm is relieved. So this is one practically possibly most useful physical maneuver. It is said that the facial nerve will be stimulated, glossopharyngeal nerve, interconnections with the vagus and superior cervical sympathetic ganglia, ultimately resulting in relaxation of the vocal cord and the vocal fold with favorable modulation. So there is a lot of interaction of the autonomic nervous system traffic. So when we speak about the management, apart from the treatment, always prevention will be best. Try to avoid or minimize the factors which we spoke about, patient factors, anesthesia factors, and surgical factors. If something is happening, recognize early and try to push oxygen with IPPV. That prevents a potential catastrophe. And if it is a risk during intubation, ensure adequate depth of anesthesia while you are intubating. So the reflex is not stimulated. And during extubation, don't extubate in between planes of anesthesia. The patient should be totally awake or patient should be deeper planes. So that's the importance of prevention. One slide about negative pressure pulmonary edema. So I told you when there is a total obstruction, what the patient would try to do is they try to have active respiratory movements, thoracic movements, and there is development of paradoxical chest movement with intercostal recession. So these vigorous respiratory activities, efforts against the closed glottis can precipitate formation of pring, sputum, cryptations, and bees, along with raised CVP. So that can precipitate an acute hypoxic episode and respiratory failure because the Starling's factors are disturbed. Okay, so basically there is increase in the hydrostatic pressure and there is a release of this water into the interstitium first, and if it continues for significantly longer time, it can also precipitate an intra-alveolar edema. One advantage, one thing we have to remember is if we are able to somehow push oxygen into the lungs and succinylcholine has worked, propofol has worked, even after the initial struggle, IPPV with positive pressure and usage of diuretics, especially furosemide, has found to be very effective. So there is no need to worry, but just keep looking for this risk. And if there is an event, attend to all these problems and monitor. And even if the patient improves, please follow up. And before the event, during the event, and post event also, everything has to be taken care of. Literature also has certain publications which are special cases. Imagine there is a report. It's a well-discussed report. Laryngospasm during subarachnoid block. Okay? Apparently, due to the parasympathetic dominance during spinal anesthesia, because of the imbalance between the sympathetics and parasympathetics in this set of patients. And there is another publication which speaks about laryngospasm caused by removal of nasogastric tube after tracheal extubation, which is a case report. And finally, there is one which speaks about the Larson's maneuver to facilitate endotracheal intubation using video laryngoscopy in an ICU patient, very interesting one. It is about an ICU patient admitted with cardiac disease, with unstable EVT. The CPR was taken up as one cycle was performed, and post-resuscitation, patient could not maintain the airway, and there was mental obtundation, a totally depressed patient. So the authors performed video laryngoscopy, but they found that the vocal cords were adducting tightly, and just the endotracheal tube touched the larynx. So, and they could not decide upon administering induction agent because patient's condition was very poor. So at that point of time, they applied bilateral Larson's maneuver and they were successfully able to relieve the laryngospasm. So in summary, it is always a risk, laryngospasm risk is hiding below the bed, rather at the head end of the operation table. And a normal protective reflex has the risk of becoming a life-threatening reflex if you don't recognize the risk and the occurrence of the event. So it can be partial or complete obstruction, and risk could be possible during intubation and extubation, but more at extubation, especially in pediatric age group, those with reactive airways and for respiratory infections, and especially involving the area around the larynx. So we have to choose the anesthetic technique wisely, patient and should be reviewed properly, and you have to recognize the laryngospasm early and manage aggressively. So this will help in preventing hypoxia and even death. So this will be the end of my presentation. Thank you very much. These are the various references. I am available at this email for any clarifications. Thank you.